My name is Barry Uretsky. I'm from the University of Arkansas for Medical Sciences in Little Rock, Arkansas. I just finished giving a review on the update of the percutaneous treatment of chronic total occlusion. I tried to make a few very straightforward points. The first point I wanted to make was that there is a misconception that the chronic total occlusion is a benign lesion due to the fact that they're collaterals to that part of the myocardium. However, the prognosis in this group of patients is actually inferior to matched patients without a CTO. So the question is, which patients should undergo percutaneous coronary intervention, or PCI, to that lesion? And in summary, what I propose is that the same rules that apply to non-CTO lesions apply to CTO. That is, to relieve symptoms after a patient is on maximal medical therapy, or when the patient has high-risk anatomy or high-risk stress test, to perform PCI with the idea to improve survival. Now, we do know already that the treatment of CTO improves left ventricular function and symptoms, and data is very suggestive that by successfully opening up a CTO, one improves long-term survival. Now, the problem has been, and in recent studies has been shown in the NCDR registry, that only about 60% of CTOs are successfully treated, as opposed to greater than 95% of non-CTO lesions. So the question is, how can we make the efficacy of the procedure better? And the way that we're doing it now is by utilizing newer techniques, which include, in addition to antegrade intraluminal approach, we have an antegrade dissection approach, now using a dedicated catheter, and retrograde techniques. So if one becomes expert in the field and utilizes all these techniques, the chance of success is at 85 to 90%. Now, let me finish by just making a suggestion how we put the recanalization of a CTO into the bigger picture of treating coronary disease. We know that the patient who is completely revascularized has better long-term outcomes than patients who are incompletely revascularized. And in the Syntax trial, the primary reason for incomplete revascularization was the presence of a CTO. Therefore, if we can predictably increase our recanalization rate of CTOs to greater than 90%, we can then have a form of therapy which we will allow the patient to have a better long-term outcome with percutaneous coronary intervention, and be it comparable to bypass surgery without the need for an operation. Those were my main points, and I thank you for your attention.